I'm going to talk, Roman suggested this title to me, Our Deceptive Mind, Why Reasoning Methods Matter, or Why Bother with Evidence-Based Medicine. I'm quite used to talking about why bothering with evidence-based medicine, but following Rowan's advice, I decided to structure my talk about the deceptive mind. And so I decided to talk about a number of different deceptive minds. The expert deceptive mind, which has to do with the first principle of evidence-based medicine. The clinical investigator deceptive mind, which has to do with the second principle of evidence-based medicine. The clinician deceptive mind, the third principle, and then we'll get to your deceptive mind with an EBM example. So, this is something called a forest plot. How many, with the way the light is, I have a difficulty seeing out there, but maybe I can. How many people in the room are familiar with this, with a plot that looks like this? Hands up. Okay, most people are, I can see that. Most people are familiar. That's great. So for anyone who is not, 1.0 means no difference between treatment and control. In this case, the treatment is thrombolytic therapy for myocardial infarction. 0.5 would mean a 50% odds reduction in myocardial infarction after thrombolytic therapy, and 2.0 would mean a doubling in risk. The dots represent the point estimates or best estimates of intervention effects as the data were accumulating, and the lines around it, the 95% confidence intervals. The first trial of thrombolytic therapy after myocardial infarction occurred in the late 1950s and enrolled only 23 patients, resulting in a very wide confidence interval. The second trial enrolled not 65, but 42 patients. This is a cumulative meta-analysis. These numbers are the total enrolled in trials up to that point. And up to 7 trials and under 2,000 patients, the confidence intervals overlap no effect. By 10 trials and 2,500 patients, it no longer overlaps no effect. By 30 trials and 6,000 patients, the confidence interval is a long way from no effect. The p-value is getting very low, and it looks like there's a 25% odds reduction after myocardial infarction with the use of thrombolytic therapy. Did this stop the randomized trials after thrombolytic therapy? No, it didn't. They enrolled another 40,000 patients after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did it happen that we have to enroll another 40,000 patients after the answer was in? Part of the explanation, I believe, is on the right side of this slide with textbook and current review recommendations that were being given as these data were accumulating, anywhere from routine, specific conditions, experimental, or not even mentioned. 2 points about these expert recommendations. First, they were regularly disagreeing with one another. Here in the late 80s, some people said routine, some specific, some calling it experimental, some not even mentioning it, and a decade before there's finally a consensus among the experts. This is a second example. This is lidocaine after myocardial infarction to prevent lethal arrhythmias. 35 years ago or so, when I was in training and rotated through the coronary care unit, I started a lidocaine drip, an intravenous infusion of lidocaine, in every patient who come through the door to prevent the lethal arrhythmias that sometimes happen after myocardial infarction. Was there ever any evidence supporting what I was doing in my training in the coronary care unit? The answer is no. Indeed, all the point estimates as these data were accumulating were on the harm side, increased death rates with lidocaine after myocardial infarction. Did this stop the experts from recommending lidocaine? No, it did not, although once again you see expert disagreement quite regularly. Most of the time, the experts were recommending this treatment, which, if anything, increased death rates after myocardial infarction. Thus, the deceptive expert mind, disagreeing with one another, a decade behind the evidence, or making recommendations that blatantly contradicted the evidence. So that leads to the first principle of evidence-based healthcare, which is individual clinical decisions and guidelines should be based on systematic summary of the highest quality evidence. The stories that I told you ended in about 1990. That was coincident with the start of the wide dissemination of systematic reviews and meta-analysis. I believe experts might still have made unfortunate mistakes, but they would never have been that blatant had they had available to them the systematic reviews and meta-analysis that would have demonstrated them the benefits of thrombolytic therapy after myocardial infarction and the harms of lidocaine. So we want systematic summaries of the best available evidence, but what is the best available evidence? Well, I like a broad definition of evidence, observations in the world, and that means that our clinical experience constitutes evidence. But when psychologists have studied human reasoning, they find we're very suspect, very tending to make specious or inaccurate causal connections. We're highly influenced by the vividness and immediacy of our observations. We're all dealing with small samples. So clinical experience can be useful, but it can be very misleading. Laboratory and physiological research is much more systematic, but generalization from that sort of research to clinical care is dangerous. And thus, we have another hierarchy, a hierarchy of evidence for therapy that EBM suggests, which is randomized trials at the top of the hierarchy, followed by observational studies looking at patient-important outcomes, basic research, and clinical experience. It's all evidence. It's all worthwhile evidence, but some evidence is more trustworthy than others. So the third principle of evidence-based healthcare is that evidence, ironically enough, evidence is never enough. And that is, we need not only evidence, but we need values and preferences. So let me ask, how many people in this room think that antibiotics are useful in pneumococcal pneumonia? Hands up. Okay, we all think so. We all agree in the evidence. Picture the following. A 95-year-old individual with severe dementia, incontinent of bowel and bladder, contractures of the hands and the feet, the arms and the legs, moaning in constant discomfort from morning to night. Nobody has visited this individual for a number of years in the long-stay care institution in which he resides. He develops pneumococcal pneumonia. How many people think it would be the right thing to do to treat this individual with antibiotics? Hands up. How many would think it's the wrong thing to do? Okay, I would say it's, again, hard for me to see, but I think it splits pretty close to 50-50 in this room, which is interesting. So when I've asked this question to many, many audiences around the world, the first dozen times or so, I did it in North America, and about 95% of the people said that no, it would not be a good idea to treat this individual with antibiotics. 10 years ago or more, at Victor Montori's invitation, Victor's one of our speakers tomorrow, today he's going to can remind me exactly when it happened, but I was in Peru and I asked this question to the Peruvian audience, and 60% of them said yes, the patient should be treated. Well, I was speaking in English. I thought, okay, we have a language problem here with this Spanish audience. I went through it very slowly, but yet 60% of the people still said, yes, the patient should be treated. I asked my host afterwards, why this difference? Think for a second what you think might be the explanation. The explanation, they told me, is a Catholic culture. When I have been in Saudi Arabia, and I asked this question, Walid, one of our speakers this morning, will likely be able to have the right guess as to what was said. 95% of the people said the individual should be treated. I wasn't sure what was going to happen when I was Thailand in a Buddhist culture. Turns out they're like North America. 95% should not be treated. What is it? We all agree on the evidence. Antibiotics work. What explains these differences? It's something we call values and preferences. And values and preferences differ between cultures and within cultures. And we had, if I got the hands up right, about 50-50 in this room. It wasn't that we disagreed in the evidence. It's different values and preferences. And it turns out we can never make our decisions. And this is my third deceptive mind, the clinician deceptive mind. If the clinicians are not aware that values and preferences underlie the decisions, we can be in trouble. So, for instance, many atrial fibrillation patients don't receive anticoagulants despite the fact that they lower strokes, and some patients, given the same surgical risk, will choose for or against a particular surgical intervention. So, because I think it is so important, I'm going to emphasize this by taking you through an exercise. This is work done by another speaker this morning, P.J. Devereux. The situation is, without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor, and 3 serious gastrointestinal bleeds in 2 years. Anticoagulants would decrease strokes in 100 patients to 4. In other words, save 8 strokes, 4 major, 4 minor. And the question that Dr. Devereux asked the individuals who participated in his study, and I am asking you now, is how many bleeds would you accept in 100 patients over a year and still be willing to administer as the clinician or take as the patient an anticoagulant? Okay? So you're reducing strokes from 12 to 4. You're saving 4 major strokes and 4 minor strokes in 100 people. How many serious gastrointestinal bleeds would you tolerate and still be ready to administer anticoagulants for that benefit? How many in the room would if there were more than 5 bleeds? In other words, you'd accept 5 or fewer bleeds, no more. How many would accept just 5 bleeds or less? Hands up. Don't see few hands. Yeah, see a few hands. How many would accept 6 to 10 bleeds? Hands up. Lots of hands going up. How many would accept 10 to 15 bleeds? Anybody with the 10? Few. How many would accept more than 15 bleeds? Hands up. Okay, this audience, if I've got it right from the hands, most of you are 6 to 10. Here's what happened when Dr. Devereux asked about 60 physicians and 60 patients. The physicians were not too dissimilar from those in this room. We had a 6 to 10 majority. Few people were 5 or less, not very many people up here. I have also asked this question to, I think probably now, it feels like dozens of medical audiences, and I have reproduced in every case Dr. Devereux's results among the physicians. But look at the patients. 2/3 of them say they're ready to accept 22 bleeds. Why 22? 22 seems like an odd number. Dr. Devereux, when he was constructing this study, was still thinking to some extent like a physician. He didn't give them a chance to say more than 22. Had he done so, they would have. We see a big discrepancy between the patients who are much more stroke averse and much less bleeding averse. Clinicians are much more bleeding averse and much less stroke averse. So, what does that mean? It means that if we follow the clinician values, we're going to be much more reluctant to give anticoagulants than if we follow the patient values. It further means, and later in this session, Victor Montori will be talking about attending to patients' values and preferences and desires, that some of the patients, most of the patients are up here, but some of them think more like clinicians. So, another problem. So, now we found out about the deceptive investigator and clinician. mind. And now we'll look at another possible deception. I'm going to ask you in a minute to put on your hat as public health officials, but before I want to do that, I want to calibrate your enthusiasm. If I say something that gives you feel enthusiastic about, I'd like you to clap. If I say something that you're unhappy about, I'd like you to indicate it. A way that, given that I'm having difficulty seeing you, to do that would be to boo. Okay? So first statement, as a reward for their hard work, all participants in this workshop will receive a week of paid vacation. All right. Thank you. When you return to your home institution, you will find news of a 20% pay cut for all physicians. Okay, excellent. Okay, well calibrated. Now we go to the exercise. So the exercise, your public health officials, and this is about your willingness to fund mammographic screening. Program A reduces the rate of deaths from breast cancer by 34%. What do you think of that program? Okay. Program B means that about 1,600 women need to be screened yearly for 7 years to prevent 1 death from breast cancer. Okay, good. Program C increases the rate of patients not dying from breast cancer from 99.82 to 99.88%. Okay, great. They're all the same program. All right? So we've now got the clinician and investigator deceptive mind, and we've got the audience deceptive mind. Okay, how does this happen? I'm going to use data from an old study of hypertension, one of the first that demonstrated the benefits of treating hypertension and reducing mortality. The death rate was 7.4% in control, 5.9% in treatment. When we say how big was the treatment effect, one way is a relative risk reduction, the control minus treatment over control, a 20% relative risk reduction. Not the whole story. We can take those with target organ damage, a 20% death rate, reduced to 16% with treatment, 20% relative risk reduction. Those without target organ damage, 5.7 to 4.5, 21%. One answer to the magnitude of effect in those with and without target organ damage, it's the same, about a 20% relative risk reduction. However, that's not the only answer. We can take an absolute risk reduction from 20 to 16% of 4%, or in the target organ damage negative, 5.7 to 4.5, 1.2%. A second answer with absolute risk reduction is 4 times as great. We can also translate this into a number needed to treat. In those with target organ damage, 25 people to prevent a single death. In those without target organ damage, 83. Putting back to the breast cancer, turns out the breast cancer deaths are very rare. 18 out of 10,000 unscreened, 12 out of 10,000. In relative effects, that's a 34% relative risk reduction. That generated considerable enthusiasm. However, you turn that into an absolute risk reduction, it's only 6 in 10,000 to a number needed to treat of close to 1,700. So unscreened, 18 in 10,000 means overwhelmingly people don't die, 12 in 10,000, still overwhelmingly they don't die, only a few deaths prevented. So relative risk reductions looked great, absolute risk reductions looked very bad. So what are the messages about our deceptive mind? Intuition is inadequate to provide optimal clinical care. We need evidence-based medicine principles to interpret the literature and apply the evidence to our patient care. So there was a description of how if we don't understand the evidence and we don't understand things like the difference between relative and absolute risk reduction, our minds are easily deceived, and that evidence-based principles can help us get around that.